The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hey everybody, Eric back with you. Today I'm going to do a Nightmare Series case, and I'm not going to give the initial information at this point. I think this is a very interesting case, something I came across, something that kind of alarmed me, and it's a little bit close to home, and so I thought it would be a great podcast, a lot of great teaching points. We're going to dive into this. We're going to go through the initial presentation and then go through a differential diagnosis and look at multiple differential diagnoses. And then we'll go through and we'll kind of dissect different aspects. We are going to hit on different lab values, kind of continue from our previous podcast over the last month, and look at white blood cell count, the different aspects of white blood cell count, look at things called like troponin and C-reactive protein and procalcitonin and all those great things, and try to tie those things into this case. All right, let's get started. You have a 30-something-year-old male patient. He has a sudden onset of tachycardia. He's at home. He's healthy, no medical history. Has no other symptoms other than that, but the heart rate is about 170 to 180. And he says that shortly after this heart rate increases to this rate, he starts having severe nausea and vomiting. The vomiting was so profound, he vomited about 30 times, and it got so bad that he actually had a syncopal episode and bailed himself down. His family called 911. His dad is actually a paramedic and actually arrived at the same time. And at this point, he's awake, complaining of burning chest pain in his upper chest and associated shortness of breath. EMS arrives. Heart rate is now between 90 and 180, so it's going back and forth, narrow complex. Based on my conversations with this patient and family, he had this feeling of impending doom. He had this feeling of that he was going to die. He had severe anxiety. EMS gave him 5 milligrams of morphine for the discomfort in his chest, gave him 5 of Valium as well, and they actually did this 2 times. So they gave him a total of 10 of morphine, 10 of Valium. They did give him 1 liter of normal saline during the transport. They started with standard oxygenation, non-rebreather, but he wasn't handling the non-rebreather. He just felt so short of breath. He had so much anxiety, so they ended up starting some CPAP on him, which was not helping as well. He arrives at the hospital. And so once he arrives at the hospital, they end up giving him another liter of normal saline throughout the first 30 minutes. They try to get him on some BiPAP. And after the second liter had gone in, the patient states that he started having some pink frothy sputum. He started coughing up that sputum, and it was approximately 800 mils total that he had coughed up. At this point, 12 lead is negative. The BiPAP is being ineffective, and he basically requests to be intubated. He feels like he's going to die. He requests to be intubated, and so he is intubated, RSI'd successfully, and then taken to the cath lab. They took him to the cath lab, and they identified prior to that he had a rapid decline in hemodynamics, and they decided to place a balloon pump. They had a few little complications placing the balloon pump, but they did place that balloon pump successfully, but he was not doing very well on that balloon pump. So very, very unstable as far as his augmentation pressures, and just not doing well at all. So let's talk about differential. This is a young patient, and to have such a rapid decline, to have all these secondary symptoms, it's really easy to automatically think cardiac. I mean, he's complaining of the burning chest pain. He's got associated shortness of breath. He's got the nausea and vomiting. I mean, all those things kind of lead up to exactly that. So obviously they thought the same thing. The 12 lead was negative, so they were attempting to rule out the MI. If you remember the past case we did on my good buddy John Malcolmson, flight paramedic for Air Methods, EMS director for a large EMS county-run agency in Elizabethtown, Kentucky. He actually suffered from a DeBakey 1 tear. So remember, a DeBakey 1 tear a lot of times will manifest with those initial rapid decompensation signs and symptoms. Obviously, this patient doesn't have the tearing pain in his back, but we need to utilize good differential diagnosis and rule those things out. And so remember, any type of thoracic aneurysm, you're going to have unequal blood pressures. Always make sure you have equal pulses in your upper extremities. Make sure you have equal pulses in your lower extremities. Always check for your pedal pulses and make sure those are equal. Make sure your blood pressures are equal. And attempt to get some type of history. Remember, DeBakey 1 tears, 40% of all DeBakey 1 tears or thoracic aneurysms are DeBakey 1 tears, affecting that whole ascending aorta. And a lot of times these patients will have a long-standing history of uncontrolled hypertension. These patients can be very young, just like this. So MI, even though we don't have a positive 12 lead at this point, we can't rule that out. With this patient having pulmonary edema, was this induced based on the volume, right? 2 liters. 2 liters isn't a lot of volume, but 2 liters is a lot of volume if you have a patient with a left ventricular dysfunction of some sort. So we have to always kind of consider, is this an inferior wall MI where you have a 50% increase in or probability of having that right ventricular infarction, right? They need volume, they need preload. Obviously, the 12 lead was negative, but they gave volume for whatever reason. I don't have actual blood pressures, but I know at that point the patient was hypertensive. Another cause of cardiac-related pulmonary edema is going to be a mitral valve papillary muscle rupture, and that's based most often on an anterior wall MI. So we know anterior wall MIs are, that high left main occlusion, most often that widowmaker, and that papillary muscle is going to control that mitral valve. That mitral valve is the high pressure valve. It has to be able to withstand a lot of pressure. And so we see these patients that will have this rapid decline, flash pulmonary edema when they do have an infarcted papillary muscle that basically blows out that mitral valve. Another differential that comes to mind for this patient would be apical ballooning syndrome. We did a podcast on this. This is called Takasobo's apical ballooning syndrome or ballooning syndrome. And this is a fairly new presentation. It was only identified by a Japanese doctor in the late 90s. But this is most often 80% seen in the female population, and it's usually associated with stress response and anxiety of some sort, a death of a loved one, and it's based on just a huge surge in catecholamines. Now, the reason why 80% of females have this phenomenon over males is males have a larger ability to handle the surge of catecholamines because of the increased muscle mass. But apical ballooning syndrome does happen in males, and again, most often associated with some type of stress response. Now, if we think back to his initial presentation, the severe nausea and vomiting, right, and the tachycardia. So he went into probably an SVT, 170s, 180s, and then if you remember, he was going from 90 to 180, so that's paroxysmal. So he's moving in and out of probable SVT. When we think about that aspect, that's going to cause a huge surge. So apical ballooning syndrome is definitely something to kind of consider. And we know apical ballooning syndrome is going to be a very severe thing if it's profound enough. Obviously, he already has pulmonary edema. He has pulmonary edema secondary to either the volume they gave, or he probably has some type of left ventricular dysfunction, right? And why would a healthy 30-something-year-old male have such a rapid decline and now have a left ventricular dysfunction issue? What about sepsis? Obviously, he fits all of the clinical signs of sepsis. Definitely falls into that Q SOFA for pre-hospital, having all his symptoms. And so I think it would be very easy to say this patient is septic. What about pericarditis? Pericarditis, what are some things that we could identify or ask? Has this patient recently been ill? Has he had an upper respiratory infection? Has somebody in his family had an upper respiratory infection or strep? Now, this patient did have an upper respiratory infection about 30 days prior. Was very mild as far as just a normal cold. But his daughter did have strep a few weeks before. And so we know with pericarditis, you're going to have global ST elevation in multiple leads on the 12 lead. Not going to have that classic reciprocal change that you would see in a normal 12 lead, where you would see reciprocal changes in your high lateral leads, in your inferior leads, right? Specifically AVL and lead 3. Those two are always going to show reciprocal when you have either a high lateral wall MI or, in contrast, an inferior wall MI. Those two will always be reciprocal, and that's one of those kind of confirming differentials to look at. If you don't have that, that's a kind of clue that you're maybe looking at pericarditis. So obviously his 12 lead is normal. He doesn't have the classic, feeling of pressure in his chest where it's relieved when he leans forward. So again, something to think about, but he doesn't really fit that criteria. And then the last one is kind of that silent killer. And the more and more I've read on this, the more and more I found this foundation. And this foundation had all these survival stories. Some of them with family members talking about their loved ones that didn't make it, that died. And it's myocarditis. And myocarditis is a really scary disease. I mean, it really has kind of rattled me reading all these different cases, because it's such a silent killer. It just sneaks up on you. And most often, patients are just going to feel kind of like they have the flu. They're just not going to feel right. And all of a sudden, they're going to start having that shortness of breath. They're going to have that feeling of impending doom, that feeling of maybe burning in their chest or chest pain. And that's exactly what this patient had. So let's kind of talk about this workup and how would you work this up and what happened when they got him to the hospital. Well, basically, after they got him into the cath lab, they identified his ejection fraction was 5% or less. So basically, that's at the point where you have pulseless electrical activity, right? That's not good. That's not survivable. On day 2, after they put the balloon pump in, as I said before, the balloon pump just was not doing what it needed to do. He was not handling the balloon pump, whether it was a timing issue. For whatever reason, he just was not doing well with the balloon pump. His temperature had increased to 104.9, so now he's very, very hyperthermic. And they made the decision to transfer him to a hospital that can put him on ECMO. So that's where we're at. The patient's transferred. He's placed on ECMO. And we'll kind of get to the end of the case here in a little bit. So let's go through the aspects of myocarditis, things that we can utilize in our everyday clinical care. And I think it'll be a really good review. Most often, myocarditis is going to be viral in nature. And these are standard viral diseases that we see all the time. A lot of them are related to our kids, pediatrics, and things like that. Obviously, myocarditis can be bacterial. It can be from chlamydia. It can be fungal in nature. So let's talk about a few of them. The first one is called Fifth's disease. And this is that parvovirus B19. So we've seen Fifth's disease. Fifth's disease is something that we see with our kids all the time. Number 2 would be that human herpes virus 6. And when I researched this is interesting that most of us are infected by the age of about a year old. And it lies dormant. It lies dormant in our bone marrow, and then it can just kind of come alive. 20% of infants brought to the ER, I thought this was very interesting, are actually suffering from this herpes virus 6. So, 20% of infants brought to the ER with just an undiagnosed, undifferentiated fever, most often it's that herpes virus 6. So I thought that was kind of interesting. And then the last one, viral-wise, is that Coxsackie virus. And this is that hand, foot, and mouth disease. Again, I've got 5 grandkids, and I think they've all had Coxsackie virus. They've all had fist disease. So that's where I start getting kind of nervous. I'm like, geez, man, this is the most common reasons why. And when I read on this and studied this, it said that specifically all three of those, that patients that have died from myocarditis, those different viruses were found in the myocardium on autopsy. This is actually the leading cause of death of undifferentiated cardiac collapse. So you have a normal young patient that just dies in their sleep. They're finding that more and more people, based on autopsy, that's the reason why they die of sudden cardiac disease. It's not cardiac disease, it's myocarditis. So viral is the most common. And then if we get into the bacterial side, so shortly after the patient got to the second facility, they did the ECMO. They identified that the patient had, with that high temperature, they identified the patient had pneumonia. So they actually did a bronch. They identified chest x-ray. He had a left-sided pneumonia, and so they did a bronch, and he actually grew staph, he grew strep, and he grew fungal. So he had a staph, strep, and fungal pneumonia. And so they identified that was probably the likely cause of the myocarditis. So they immediately started him on a very focused antibiotics. So they started him on Zyvox, antibiotic called cefepime, and then they started him on Flagyl. So they hit all 3 of those, and all those are very focused antibiotics that really hit on tougher strains, maybe bacteria that doesn't respond to just the standard antibiotics. And so these are very, very potent. As far as labs go, his labs were pretty profound. He had a troponin level of 11. So we know a normal troponin is 0.01 nanograms per deciliter. And we know that, a lot of times troponins can be elevated for other reasons, but, it doesn't always mean that it's a cardiac related MI or something like that. But obviously this is a big deal. You have inflammation around the heart, that myocarditis. And so a troponin 11 is pretty significant. What about sepsis? Like if we think about sepsis and we think about looking at the different labs and we think about identifying, is this patient in septic shock? Now, obviously, he has a pretty profound pneumonia. He has strep, he has staph, and he has a fungus. So what other labs can we do to kind of help us in that initial differential? Imagine if this patient was a patient that you were picking up from a hospital. And one of the really cool not medications, but the very cool labs that they're utilizing a lot more now is a lab that's very focused on looking at a bacterial infection, and that's procalcitonin. Procalcitonin is basically a chain of amino acids. So it's made up of 116 amino acids. And a normal procalcitonin level in a person, in an adult, is less than 0.15 nanograms per deciliter. So a normal healthy person, basically their levels are below that, and they're below that based on just normal detection. So we shouldn't ever see a high procalcitonin. If you do, basically there's different levels. So you have mild. A mild increase is going to be between that 0.15 to 2 nanograms per deciliter, and that's going to just focus you in on maybe a mild bacterial infection, maybe a non-infectious surge response, so a systemic inflammatory response of some sort. Or you may see that in patients that have that end-stage renal failure. Where it becomes diagnostic is when it's greater than 2 nanograms per deciliter. And so at that point, it's very specific for a bacterial sepsis, bacterial pneumonia, meningitis, or peritonitis, something like that. And so it's really, really good, and it focuses in on that bacterial inflammatory response, or that surge response. When we think back, we used to always look at lactate, and lactate is still a great marker, but we know that lactate is not an indication of infection. It's not an indication of tissue hypoxia, but it does help us kind of relate and identify how sick is this patient. And so a lactate level tells us of a stress response. Remember, lactate is a byproduct of glycolysis. And glycolysis, whether you're thinking of aerobic glycolysis or anaerobic glycolysis, your lactate is a byproduct of both. We know that lactate is very important in our processes for fueling our brain and our heart. And so a lactate doesn't tell us that we have an infection. It just tells us our body's under a stress-related event. So his lactate, they did draw lactate, and his lactate was 11. Now, we have different levels of lactate, and so when you see a lactate of greater than 4, and you're getting up to 11, that's a pretty big stress response. And, anytime you get high like that, you need to start looking at other causes, right? There's other reasons why, and one of the ones that really sticks out to me is a metformin metabolic acidosis. So metformin is that medication for type 2 diabetes, and there are patients that just don't respond well. They become very toxic, and that will cause a very high lactate in a metabolic acidosis. All right, another lab is C-reactive protein. And C-reactive protein, a norm is going to be less than 1 milligram per liter. This is kind of one of those labs that's really more non-specific. They check this, but it's used for lots of different ways. And so a high level of that C-reactive protein marker is an indication of inflammation, just an inflammatory response of some sort. It can be high for a lot of reasons. It can be high for just standard infection. It can be high in cancer patients. But it's also used to kind of look at and identify a risk for heart disease. And so somebody that has a C-reactive protein between 1 and 3 milligrams per liter, they have about an average risk for heart disease. If it's greater than 3, they have a pretty severe risk for heart disease. And anything less than 1 is normal. So his C-reactive protein was very elevated. It was greater than 3. So again, that doesn't mean that he has a high risk for heart disease. It just means that he has a severe inflammatory response. So again, it's very non-specific to what's going on in the grand scheme of things. Okay, so we've hit on lactate, we've hit on C-reactive protein, we've hit on procalcitonin, we've looked at his troponin level. So now let's look at the white blood cell count. We've talked about a lot of labs. We talked about a lot of labs with the podcast with my wife on the other day, and we looked at that endocrine case and touched on a lot of those things. And so let's talk about white blood cell count. When we look at the white blood cell count and we identify if they have some type of infectious process, we need to first kind of go through, and there's lots of different aspects to a white blood cell count. So we're going to go through each one of them. We know a white blood cell count has a level between 4,500 and 11,000. And any cell that starts out is called a blast cell. A blast cell is basically make up red blood cells, white blood cells. All the cells, when they're maturing, are called blast cells. So a white blood cell, once it's mature, again, 4,500 to 11,000. And when we see white blood cell counts that are less than 4,500, a lot of times that's caused from an immune response. So it can be mono. Obviously, cancer will cause this. Autoimmune disorders like lupus, obviously infection, specific medications will also cause this. And then high counts, you can see that in leukemia. You can see that in a stress response. You can see that in tissue damage like burns, and then obviously bacterial infections. So when we think about white blood cell count, there's different kind of aspects to white blood cell count. And the majority of white blood cells are made up of neutrophils. And neutrophils, that's the way our body responds and fights infection. So that's our immune system response. And that makes up 50 to 70% of all of our white blood cells. And when we look at a white blood cell count, you're going to have different aspects. You're going to have the neutrophils, you're going to have bands, you're going to have basophils, you're going to have eosinophils, etc. And we're going to go through each one of these. When you see bands on a white blood cell count, bands are essentially immature white blood cells. And so when you see a band level greater than 10%, that's not saying that it's specific for a bacterial or an inflammatory response. So it's not specific, but it's better to use absolute white blood cell counts or neutrophils as diagnostic. But what that means is that there's a good likelihood that for whatever reason, our body is trying to produce white blood cells because it's trying to fight some type of infection or inflammatory response. And that's where you're going to see bands, which are, again, those immature white cells. The next white blood cell is a basophil. And basophils are used in the inflammatory response. Think about allergic reaction. And these cells produce immunoglobulin E. And these are those antibodies that fight these inflammatory responses related to an allergic reaction. So again, basophils, think inflammatory response, think allergic reaction. We also have a white blood cell called an eosinophil. And eosinophils are also seen in allergic reactions, and more so in the extreme allergic reaction. You also see these elevated in the initial stage of Cushing's disease, and we know that Cushing's disease is caused by too much steroid hormone. So people that are on long-standing glucocorticosteroids, maybe bodybuilders that take steroids, or athletes that take steroids, they can actually get Cushing's disease. And you can also see an elevated eosinophil level with maybe a parasitic infection of some sort. The next one is a lymphocyte. And lymphocyte, these are our killer T cells, our killer B cells. So these are those cells that are constantly produced in the bone marrow, and they become lymphocytes. So some of these will enter your bloodstream. Most of them are going to move through your lymphatic system. And we know that your lymphatic system is a group of tissues and organs like your spleen, like your tonsils, like your lymph nodes. And these protect our body from infection. So about 25% of these new lymphocytes remain in the bone marrow. Some of them become B cells. But again, the majority of them, about 75%, travel to your thymus and become T cells. And then the last one is going to be your monocytes. And monocytes are produced in the bone marrow. They then enter the bloodstream, and they account for about 1 to 10% for very, very small amount of the circulating leukocytes. So we have a small amount, 200 to 600 monocytes per microliter of blood. So again, in comparison to your other white blood cells, specifically if you compare that to your neutrophils, very, very tiny amount. After a few hours, though, they migrate to tissues such as your spleen, liver, lungs. They again go into your bone marrow, where they mature into macrophages, and they're the main scavenger cell for our immune system. So these are those macrophages that try to eat up this infectious process. So that's basically our overview of labs for this case. I want to kind of give a shout out to this patient. His name is Darren Vandergriff. He is a flight paramedic and a training chief, for a captain, I guess, for a department down in Atlanta, Georgia. He is a great guy, and somebody I've become to know. I know his dad really well, Larry, and we've done review classes down there. He was extubated on day 6. He was moved to a high-frequency nasal cannula to kind of wean him off, and the ECMO was then removed on day 7. On day 7, they evaluated his ejection fraction. It had improved to 25%. By day 8, the pneumonia, remember the pneumonia was strep, staph, and fungal, had subsided, so at day 8. And then 1 day prior to discharge, his ejection fraction was determined to be 45%. He had some mild left ventricular hypertrophy, but they told him that through medications, rest, and some exercise, that it would basically remodel and go back to normal. So this case is a reminder that we never, ever know. And myocarditis is one of those sneaky diseases. It can come on instantly. It's going to come on and it's going to mimic a lot of vague symptoms. We saw on our differential that we looked at an MI. He presented similar to a DeBakey 1 tear. He presented similar to a mitral valve papillary muscle rupture, apical ballooning syndrome. I mean, this would be a classic apical ballooning syndrome. He definitely seemed like he was septic. You could also then think about pericarditis, but I think most of us are going to not think about myocarditis at all. And when you think about his massive, rapid decline, shortly after arriving at the hospital, his ejection fraction is 5%. I mean, that's really, really bad. And so think about a normal, healthy person with a rapid decline like that. I mean, I encourage you to research this. There's a great website. It's basically a myocarditis foundation, and you can read all these survival stories. This happens to little kids, happens to every age group. Some make it, some don't. And we have to really be, I think, ahead of the game when we try to identify this. And I think aeromedical-wise, pre-hospital-wise, when you see patients that present like this, we have to always have this in the back of our mind. And again, this presentation, seeing him go through this has definitely made me more cognizant of it. And I just want to give a shout out to him and say, on behalf of everybody at FlightBridgeED, we love you, and we're so happy that you're better and you're back to teaching and providing care to our patients out there in the Atlanta metro area. We look forward to seeing you when we do our review class in September. I will put a picture of him, pretty cool. His dad sent a picture of him after they extubated him. I guess the first book he wanted to look at and read was the ventilator management book, so that was pretty cool. So we're going to put a picture on the podcast, on the website of him, based on his permission. And if you have any questions, you want any more information on Darren, just let me know. Email me at eric.bauer@flightbridgeed.com. Check out our website. Fast 18 is going to be epic. I can't stress that enough. We have world-class speakers. We're going to release those names very, very shortly. Venue in Nashville, Tennessee, we're going to announce very shortly. And just very excited about being able to provide this conference and bring these amazing speakers locally to the Nashville area. Very, very short drive from many states, right? 5-hour drive from, man, you could probably say 10 states. So travel is going to be cheaper than it would be to fly across the country. And that is why we're doing it. 3 different pre-cons at this point. We're going to do Dr. Dan Davis's heart training, which is absolutely amazing. It's basically a resuscitation training that's meant for physicians, and we're bringing it to our pre-hospital providers. Dr. Dan Davis and I have been discussing, and we're going to kind of do a strategic partnership. He's coming on board as a medical director, scientific kind of advisor for us, and we're going to start promoting this course and teaching this course. We're also going to do have Brandon come in and have him come in and do his EMS POCUS, which is exciting. And we're going to have Dr. Peter Antevy come in, and he's going to do his Antevy Pediatric Provider course. And so that's really, really exciting. So check it out. Register. We're only going to have a maximum attendance of 300 people. So that's not something we've really discussed. 300 people is it for our first conference, and that's just based on venue size, and we just don't want to overdo it the first time. So please check that out, register, get your spot, and again, if you have any questions, you want to schedule a review course, a ventilator course, just reach out to me and send me your flights, your cases. Obviously, we change everything up, but if you have any questions, you want to discuss anything, reach out to me. Again, thank you so much, and I will talk to you soon.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.